Welcome back, class. Let's jump right in. Today, we're tackling a massively high-yield topic for your pharmacology exams. We're talking a 25-mark long-answer question. We are going to master the complete pharmacological management of bronchial asthma, and crucially, we're integrating the absolute latest Gina 2026 guidelines. This explainer is designed to be highly visual, straightforward, and packed with exactly the details you need to ace your boards and become a much safer prescriber.
Here's our roadmap for this explainer. This is going to serve as your cognitive scaffold. We'll start with pathophysiology basics, move through our core pharmacological agents and newer biologics, break down the major Gina 2026 updates, cover acute emergency management, and finish up with some rapid-fire exam pearls. Section 1. Asthma Pathophysiology Basics. Understanding the enemy. Because, let's face it, before we can deploy our pharmacological weapons, we've got to understand the exact biological enemy we're up against.
So jot this down. Asthma isn't just simple mechanical bronchoconstriction. No, it is fundamentally a chronic inflammatory disease. When someone with a genetic predisposition encounters an allergen, it kicks off this massive immune cascade. It activates Th2 lymphocytes, pumps out IgE, and triggers mast cells and eosinophils. These cells then just dump powerful mediators like histamine and leukotrienes straight into the airway, causing bronchoconstriction, mucus hypersecretion, and really severe inflammation.
And you can see this biphasic response play out beautifully right here. See that immediate drop in airway function right after allergen exposure? That's the early phase bronchospasm. That's your mast cells degranulating. But look at what happens hours later. A second prolonged drop? That's the late phase, and that is purely driven by inflammation from an influx of eosinophils and Th2 cytokines. This two-part attack is exactly why our treatment strategy needs two totally distinct classes of drugs: bronchodilators to rescue that early phase, and anti-inflammatory controllers to shut down the late phase.
All right, moving on to Section 2, Core Anti-Asthma Pharmacology. Let's start building out that foundational therapeutic arsenal. Now, if you can recreate this exact drug classification table on your exam, you are golden. It instantly tells the examiner, hey, I understand the fundamental difference between symptom relievers and underlying disease controllers. On the left are bronchodilators, beta-2 agonists, anticholinergics like ipratropium, and methylxanthines. On the right are vital anti-inflammatory controllers, glucocorticoids like budesonide, leukotriene modifiers like montelukast, and mast cell stabilizers like sodium chromoglycate. Let's zoom in on those beta-2 agonists. They stimulate beta-2 receptors to bump up cyclic AMP and relax that smooth muscle. But you have got to know the difference between SABA and LABA. Short-acting agents, your SABAs like salbutamol, act immediately, peaking in 30 minutes and lasting maybe 3 to 5 hours. Classic rescue drugs. But your long-acting agents, your LABAs, like formoterol, last a solid 8 to 12 hours. And here is a massive exam pearl for you. LABA monotherapy is absolutely contraindicated in asthma. You have to give them as an adjunctive therapy alongside an inhaled corticosteroid. Speaking of which, corticosteroids are quite literally the cornerstone of asthma therapy. They're your heavy hitters, the most effective controller drugs we have, because they potently inhibit T-cell activation, dropping those Th2 cytokines and eosinophils. We're mostly using inhaled versions, or ICS, like fluticasone. For severe acute attacks, sure, we'll go systemic with oral prednisolone or IV hydrocortisone. But do not forget to write down the classic localized side effects for inhaled steroids: oropharyngeal candidiasis, which is oral thrush, and dysphonia, that croaky voice. Always tell your patients to use a spacer and rinse their mouth out.
Now consider theophylline. It's a methylxanthine that inhibits phosphodiesterase. It definitely works, but it has a notoriously, and I mean notoriously, narrow therapeutic window. If plasma concentrations push past 200 micromoles per liter, you are risking fatal cardiac dysrhythmias and severe CNS seizures. So yeah, handled with extreme caution. We also have ipratropium, blocking M3 muscarinic receptors to dilate airways and cut down mucus. And finally, montelukast, an orally active antagonist at the cystenyl leukotriene receptor.
Next up, Section 3, Advances in Biologic Therapies. Because to ace a modern pharmacology exam, you absolutely have to know your targeted immunotherapies.
This breakdown is incredibly high yield for your multiple choice questions. You've got to map the exact biologic to its immune pathway target. Severe allergic asthma, we use omalizumab to target and bind free IgE. What about eosinophilic asthma? We're going after interleukin-5 with mepolizumab or benralizumab to kill off those tissue-damaging eosinophils. For broader type 2 inflammation, Dupilumab hits the IL-4 and IL-13 pathways. Oh, and definitely note tezepelumab. It's a recent first-in-class TSLP blocker for severe asthma. All right, Section 4, the latest Gina management guidelines for 2026. Get ready because we are talking about a major paradigm shift here.
I want you to write this in big, bold letters in your notes. Prescribing short-acting beta agonists alone is completely outdated. It is strongly discouraged by Gina. Why? Because treating a patient with just a SABA is like putting a Band-Aid on a bullet wound. It handles the immediate bronchospasm, but it leaves that dangerous underlying airway inflammation completely unchecked.
So, what's the new standard? Gina strongly prefers track 1. For mild asthma, steps 1 and 2, we use a low-dose ICS formoterol combination purely as an as-needed reliever. Then, as we step up to moderate and severe asthma in steps 3, 4, and 5, we use that exact same ICS LABA inhaler for daily maintenance plus as-needed relief. And we can eventually add in biologics or oral steroids if things still aren't fully controlled. This single inhaler strategy is an absolute game changer. It massively reduces severe exacerbations. Think about it. Every single time a patient reaches for their inhaler because they're wheezing, they're automatically getting a hit of anti-inflammatory corticosteroid. It cuts down hospitalizations, lowers mortality, directly fights the inflammation, and obviously patient adherence skyrockets because they only have to keep track of one inhaler. The whole shebang. Let's pivot to Section 5, acute severe asthma therapy. Because when a patient rolls into the ER deteriorating rapidly in status asthmaticus, there's no time to guess. Every second counts.
Here is the exact sequential protocol you need to run. First, oxygen. But hold on. Only if their SpO2 drops below 92%. Pumping them with excessive oxygen can actually make things worse. Second, hit them with nebulized bronchodilators right away. We're talking salbutamol mixed with ipratropium to literally force those airways open. Third, you've got to stop the inflammatory cascade with life-saving systemic corticosteroids, like IV hydrocortisone or oral prednisolone. And finally, if there is no response, we pull out the IV magnesium sulfate or slow intravenous aminophylline.
All right, home stretch, Section 6, high-yield exam pearls. Let's do a rapid-fire review to really lock these critical concepts into your brain for test day. Question 1. Think back to that massive paradigm shift we just talked about. What explicitly replaced SABA monotherapy? You got it, low-dose ICS plus formoterol. Never, ever forget that the single inhaler strategy is the new gold standard of care. Okay, next up. This is a classic board exam scenario. You've got a patient with nasal polyps who suddenly develops an acute asthma exacerbation right after taking an NSAID. Which specific drug is going to be your best friend here?
The answer is montelukast. See, aspirin-sensitive patients actually overexpress cysteinoleucotriene receptors. Montelukast swoops in, blocks those exact receptors, and is basically tailor-made for this specific subgroup.
Let's do one last one. Think back to that methylxanthine drug with the terrifyingly narrow therapeutic window. If those plasma levels spike too high, what are the life-threatening consequences? Fatal cardiac dysrhythmias and severe central nervous system seizures. Nasty stuff. So here's my final provocative thought for you to chew on as we wrap up this explainer. With the rapid rise of incredibly safe, hyper-targeted biologics like dupilumab and omalizumab, how much longer are we really going to keep highly toxic, narrow-window legacy drugs like theophylline in our clinical arsenal? Something to ponder. Thanks for tuning in, class, and go crush those pharmacology exams.